Prostate cancer. It's the biggest hitter after skin cancer for men, and yet, statistically, most men who die from it didn't have to. That's not a scare tactic. That's just where the numbers land when you catch things too late. Here's the thing that surprises people. Prostate cancer is often one of the slowest moving cancers there is. Some men live decades with it and never know. So why does it still kill so many? Because the ones that turn deadly are usually the ones nobody was watching for. No symptoms, no red flags, until it's already spread. And this isn't new. Men have been dying quietly from this one for generations, long before we even had a name for the gland causing the trouble, because it sits so deep in the body that early problems just don't announce themselves the way, say, a lump in the breast might. So, in this video, I want to walk you through the 4 things that actually determine whether prostate cancer gets caught in time, and I'll throw in a bonus at the end, a specific number, a PSA threshold guideline, that a lot of men have never heard explained properly. I'll flag that one for double checking, but I think it's worth knowing. Now, quick intro for anyone new here. I'm Dr. Victoria Ellery. I've spent years in general practice seeing this exact scenario play out, guys in their 50s and 60s who felt fine right up until they didn't. Just to say up front, I'm not your physician. This is educational, not a diagnosis or a treatment plan. Please talk to your own doctor about your own risk. So let's start with the mechanism, because once you get this, everything else makes sense. Think of the prostate like a walnut-sized gland sitting quietly at the base of the bladder, and cancer there, early on, is like a fire smoldering in a room with the door shut. No smoke alarm, no smell, nothing reaches you until the door finally opens. That's the challenge. There's no nerve-rich lining screaming, something's wrong, the way you get with, say, a stomach ulcer. It just grows, slowly, silently, until it either presses on something or escapes the capsule entirely. First factor, age and family history. This is really about your baseline risk, and it changes the math on everything else. Research has shown that risk climbs meaningfully after 50, and if you got a father or brother who had it, that risk roughly doubles. Some studies suggest even more if it was diagnosed young in that relative. I think about the guy who comes and saying, well, my dad had it in his 80s, no big deal. But if it was his dad at 55, that's a completely different conversation. Takeaway: know your family's history, specifically the age of diagnosis, not just the yes or no. Second, PSA testing itself, prostate-specific antigen. Here's the analogy I like. PSA is like a smoke detector, not a fire alarm. It doesn't tell you where the fire is or how big. It just tells you something's off and worth a closer look. It's a protein the prostate makes normally, but when something's disrupting the gland structure, inflammation, enlargement, or cancer, more of it leaks into the blood. Studies suggest regular PSA testing, especially watching the trend over years rather than one snapshot, is one of the better tools we have for catching things early, even though it's an imperfect one. I've had patients whose single PSA looked normal, but the rate of rise over 2 years was the actual red flag. Takeaway: ask for your PSA trend, not just your latest number. Third, the digital rectal exam. I know, nobody loves hearing this one, but let's talk mechanism, not embarrassment. The prostate sits right against the rectal wall, so a physician can actually feel its surface directly, checking for hard spots, asymmetry, texture changes, things a blood test alone might miss. It's like checking a peach for a bruise, by feel rather than just looking at the skin. Research has shown that combining this exam with PSA catches more early cancers than PSA alone. It's 30 seconds of discomfort, and I always tell patients that's genuinely nothing compared to what early detection buys you. Takeaway: don't skip the exam just because the blood test came back fine. Fourth, urinary symptoms. And this is the tricky one, because by the time these show up, it's often a benign enlargement, not cancer, but you can't tell the difference just by how it feels. Weak stream, frequent nighttime urination, a sense of incomplete emptying. Mechanically, that's the prostate pressing on the urethra like a hand squeezing a garden hose. Studies suggest men chalk this up to just getting older, for years before mentioning it to anyone. And look, most of the time it's not cancer, but the only way to know is to actually get it checked instead of assuming. Takeaway: any new urinary change after 50 is worth a conversation, even if it turns out to be nothing serious. Now, a couple of watch-outs. First, PSA testing alone, without context, can lead to overdiagnosis, Some slow-growing prostate cancers would never have caused harm in a man's lifetime, and treating them aggressively can do more damage than the cancer itself would have. That's a real, honest limitation, and it's part of why doctors now talk about active surveillance instead of jumping straight to treatment. Second, watch out. Don't rely on symptoms alone as your screening tool. Remember, the dangerous kind is often the quiet kind. And third, I gently push back on the idea that supplements or specific diets can shrink prostate cancer risk dramatically. The evidence there is much thinner and more mixed than the marketing suggests. Okay, for the bonus, I think this is worth knowing. There's a general PSA threshold. I believe it's often cited around 4.0 nanograms per milliliter. That's traditionally used as a point where further testing gets seriously considered. Though if I'm remembering that right, the actual cutoff conversation has gotten more nuanced over the years, factoring in age and PSA velocity rather than one flat number for everyone. The mechanism's the same as before. It's a threshold built from population-level data on which levels correlated most with detectable disease. Takeaway: don't fixate on a single number in isolation. Ask your doctor what your number means in the context of your age and history. I hope this was helpful. Stay healthy, and I'll see you in the next one.